Today I'm going to be measuring Muhammad's active range of motion at his proximal interphalangeal joint. To measure this, we're going to have him seated with his forearm supported by a table, elbow in a 90-degree angle, and his forearm will be in neutral. In order to measure the range of motion, the stationary arm is going to be the proximal phalanx, the moving arm is going to be the middle phalanx, and your axis is going to be the PIP joint. I'm going to be stabilizing the proximal phalanx. I'm going to have you bend your finger like you are grabbing a can. All right. His range of motion was 105 degrees, which is in the normal ranges of 100 to 120 degrees. So now we're going to move on to passive range of motion. In order to do this, I'm going to stabilize the proximal phalanx. I'm going to then move the middle phalanx through passive range of motion. This is to test for the infeel. His infeel is firm, which is typically created by the stretching of the dorsal aspect of the articular capsule. One of the main things we're testing this for is to make sure that there are no abnormal infeels, such as bony infeel, which could be created by arthritis or some bone spurs. Today I'm going to be performing a manual muscle test on Chloe's forearm pronation. In order to do that, I'm going to have her seated. I'm going to have her elbow placed at a 90-degree angle. First, I'm going to passively walk her through the movement. So you're going to start in neutral. You're going to twist your forearm like this. Can you do that for me? So while she actively did that, I palpated for pronator teres and felt the activation there, and she had full active range of motion, so we can proceed by adding resistance to the movement. So I'm going to stabilize by placing my arm against her distal humerus, and then my other arm is going to go at the distal end of the radius in the ulna. I am stabilizing the humerus to prevent shoulder abduction, and my force is going to be applied in a circular direction, attempting to force her forearm into supination while she attempts to maintain pronated. So I'm going to attempt to supinate you. You stay pronated, hold strong, don't let me move you. All right. So there was a little bit of movement there. I would score her at a 4 out of 5. If she was not able to go through the full active range of motion on her own, we would move her into a gravity eliminated position, which would be on a table with the shoulder into 90 degrees of flexion, the elbow into 90 degrees of flexion, and then she would attempt to pronate from this position. We were doing this to test for activation from pronator teres and pronator quadratus. We're able to palpate pronator teres, which is innervated by the median nerve, which comes from spinal roots C5 to T1, and pronator quadratus is more difficult to pronate or more difficult to palpate due to how deep it is, but it is innervated by the anterior interosseous nerve, which is a branch of the median nerve and also extends from spinal nerve C5 to T1. Today I'm going to be testing Chloe's sensation around the T1 dermatome. We're going to be using a cotton ball for the light touch sensation method. Have you ever had a sensation test performed on you before?
No.
No? Can you stick your hand out? I'm going to show what it feels like. That is what it's going to feel like.
Okay.
Okay, so now I'm going to touch one area on your left arm, and then I'm going to touch the same area on your right arm. I want you to tell me whether it feels the same or different.
Okay.
Okay? So you're going to start. Close your eyes, please.
Okay. Same. 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 Same.
All right, so She scored a 5 out of 5, which would indicate a 2 on the sensation scale. If she had some discrepancies, did not feel them on one side or they felt different on the other, if it was a 3 out of 5, I would have scored her at a 1 on the scale. And if she had no sensation on one side and normal sensation on the other side, I would have scored it at a 0. Differences, discrepancies in these, or a 0 could be indicative of nerve damage leading to a lack of sensation at the T1 spinal nerve. Today I'm going to be performing the deep tendon reflex for C7. Have you ever had your reflexes taken before?
Yes.
Yes? Just as a reminder, I'm going to show you what it's going to feel like. Okay, not too bad. The C7 deep tendon reflex is located at the tendon of the triceps. In order to test this, I'm going to have my patient in a seated position. Her shoulder is going to be slightly abducted and extended. Elbow is going to be slightly flexed, and the entire upper extremity is going to be relaxed. I'm going to support her upper arm with either my hand under the biceps or humerus, or I can wrap my arm underneath. First, before I do that, I'm going to palpate for the tendon of the triceps. In order to do that, I'm going to have her attempt to extend. All right, so it is right there. Going to then support her arm. Remember where the tendon is at. And now we are going to test the reflex. Okay, so I did see the muscle belly contract, and I also saw a little bit of movement at the joint. That would be indicative of a 2+ on the scale. The scale ranges from a 0 to a 4+. A normal is a 2+ for most people. It could also be a 1+ or a 3+ if it is the same bilaterally. For most patients, I would test them on both sides and compare the two sides. A 0 or a 4+ would be abnormal for everyone. It would also be abnormal if one person had a 2+ on one side and a 0 on the other side, or a 3+ on one side and a 1+ on the other side. A 0 or a 1+ would be indicative of hyporeflexia, which could be a result of a lower motor neuron lesion, and hyperreflexia, either a 3+ or a 4+, could be indicative of ALS or MS.